Good afternoon, and thank you for being here. I'm a postdoc here in the Miami project, and I've been working with Jaylee and Nagy, Ayad. And today I'm gonna share with you some of the data we got developing anti-inflammatory strategies using nanomaterials for spinal cord injuries. And this image here, I'm showing you some of the reactions that happen right after injury. This is a contusion injury induced in mice, and at 3 days post-injury, you see infiltration of these immune cells labeled in red. These are macrophages, and then astrocytes also react to form a glial scar. So there's a very strong immune reaction in the tissue, as you can see. So for today, I'm gonna mention briefly the pathology of spinal cord injury. You are familiar with it, I believe so I'm not going to focus too much on that. But I'm going to try to focus on the inflammatory processes that occur after spinal cord injury and what strategies have been used to reduce this inflammation and induce neuroprotection of the tissue. Then I'm going to suggest some strategies involving biomaterials, and I'm going to show you some biomaterials that can be used for spinal cord injury repair. And then I'm going to go over some of the data in our project. So one of the projects has to do with the development of a nanoscaffold that we implanted and evaluated in the spinal cord. And then I'm going to mention our most recent project that actually we're just starting, and that involves cell-specific therapies to target inflammation again by using particles for spinal cord injury. As I go along, I'll tell you about our ongoing investigations and also the future directions for our projects. So briefly, spinal cord injury is very complex. There's a series of events that occur through time after the injury. This is a very simple way that I'm trying to represent that we can divide the stages after injury in these phases. So we can call this immediate phase in the first couple hours after injury, followed by an acute, subacute, and intermediate and chronic phase. And these are important because at different stages after injury, we have different cellular reactions and molecular reactions. Initially, we have very strong inflammation and cell death caused by the mechanical injury and also the expansion of the secondary injury. And then we have attempts of the tissue to repair through tissue replacement. So we have proliferation of cells and even endogenous stem cells trying to repair. And then finally, we have also the tissue remodeling that involves the presence of scars. As you know, the glial scar, the fibrotic scar, there's remyelination and also axon sprouting in an attempt to repair the circuits. But as we all know, this is never resolved. And even in chronic stages, we have cystic cavities that prevent regeneration. We still have immune cells present even at years after the injury. So there's a need for effective therapies to repair the spinal cord. And I have here on the bottom part of my slide some of the suggested therapies for each of these phases. So, of course, after injury, immediately in the clinics, hemodynamic control, so maintaining the arterial pressure, is essential, stabilizing the neck and the spine, and also decompressing the cord with surgery techniques is essential to stop the progression of the injury or try to prevent further loss of function. And then it's also agreed in the community that neuroprotective strategies should start as early as possible. These include anti-inflammatory and other approaches. As we move on and we enter the subacute phase, we also have a lot of preclinical data suggesting cell therapies, and the Miami project is also exploring that in clinical trials and other groups. Once we enter the late stages of the injury, the therapies focus different things, such as the scars and degrading the scar, filling the cavity with a material to try to regenerate, and also rehabilitation is a very important strategy in the chronic phase. So from here, if we focus on the inflammatory process, we have the cell infiltration that you can see represented in the top part of this timeline, and then the inflammatory mediators that come with those cells. So this is a timeline based on data from rodent models. The dashed lines are for mice, and the continuous line are in what happens in rats. So microglia are obviously the first immune cells to react to this injury, and they start producing a number of inflammatory cytokines. Then we have infiltration of neutrophils that peaks at around 24 hours. This is followed by a gradual infiltration of other cells, such as monocytes and lymphocytes, that, if you notice, is never resolved, and especially, I knew this was going to happen. Especially here in the chronic phase, we still have a lot of macrophage infiltration, and the inflammation is not resolved. So a number of strategies have been proposed to reduce this inflammatory response, and I'm stressing these ones because there's a strong body of data from the preclinical data pointing out towards beneficial effects in these ones, and they're also in clinical trials. So as I mentioned, surgical decompression is something that it's done in the clinics to alleviate the pressure that is created after the injury. Therapeutic hypothermia is also being investigated, so you temporarily reduce the temperature of the body, metabolism comes down, and there's a series of benefits to that. And there's a number of pharmacological interventions. I am focusing on these ones because, again, they're in clinical trials, and there's a lot of data towards the use of methylprednisolone, riluzole, and minocycline, all as anti-inflammatory neuroprotective strategies.
You just mentioned therapeutic hypothermia. We have a multi-center trial ongoing right now. We've got about 6 institutions recruiting subjects to maintain normal thermia versus hypothermia, which is 33, 34 degrees.
Right.
It looks like the recruitment's going slow, but it looks like it's going well. And we just had an external review, and it looks pretty promising. It looks like they didn't stop the trial, so that's always encouraging.
Yeah. Exactly. I was going to mention that right now. All of these strategies have passed the safety phase, so phase 1 of clinical trials, and they're now on phase 2 and 3. Some of the mechanisms associated with each of these interventions are mentioned here. So minocycline is an antibiotic. There's actually not a lot of data regarding the mechanisms, but it has been shown to be neuroprotective. It's in an ongoing clinical trial in Canada. And then riluzole, I believe University of Miami is also involved in this trial that also has passed safety. Riluzole is a sodium channel blocker and reduces excitotoxicity, and then is neuroprotective. And finally, hypothermia, as Dr. Dietrich mentioned, they're also recruiting patients, and it reduces inflammation, decreases microglia activation, and has a number of benefits that are being investigated in patients. However, at the moment, we don't have an effective therapy for spinal cord injury. It's very much needed. The drug that has been more studied is methylprednisolone. There were 3 clinical trials looking at the effects of methylprednisolone. I'll start saying this is a very controversial treatment option. The mechanisms that are associated with the action of methylprednisolone are scavenging of free radicals, inhibition of lipid peroxidation, inflammatory cytokines, reduction of immune cell infiltration, also astrocyte proliferation. There's also something in the literature that points out to increase in trophic factors such as NGF after administration of methylprednisolone. However, in order to have this to happen, these beneficial actions, you need to systemically administer a very high dose of the drug. And in the clinical trials, the patients experience severe gastric bleeding, wound infections, pneumonia. There was even some mortality. So although there's still a recommendation for the use of methylprednisolone, it is very controversial. Some clinicians are not using it anymore, and if they use, they have knowledge of these possible very negative side complications. So we need more effective strategies. And when designing strategies for delivery of drugs to the spinal cord, we need to take into the account that it's challenging because in the normal spinal cord, as you're probably familiar with, we have this neurovascular unit. So the blood-spinal cord barrier is formed by these, the capillaries have specific characteristics in the CNS, so they have tight junctions, the endothelial cells. They're surrounded by pericytes, astrocytes, and other cells that actually prevent most drugs to enter the tissue. What happens after spinal cord is that during those initial phases that I mentioned, and I'm sorry, this barrier is actually compromised because there's disruption of the blood vessels. So we have an opportunity to access the cord. But again, we need to have high dose of the drugs to potentially reach the lesion site. And along the way, there's several things that can reduce the availability of these drugs, even if they reach the site. So some of them are lipophilic drugs that are very commonly used. They actually interact with hydrophobic pockets of the plasma proteins. So in there, you're capturing some of the drug and limiting how much it accesses the lesion. Some of them have short half-lives. They're also degraded along the way. And they're obviously, if there's no targeting strategy, they're going to be diffused to other tissues and still cause these side effects. So what I'm suggesting today, and it's not new, a lot of people have been investigating this, is suggesting the use of biomaterials for local drug delivery to the spinal cord. So I'm mentioning three different classes of biomaterials that we can use if we think of spinal cord injury repair. Particles, and when I say particles, it's either at the nanoscale or microscale. We can talk about nanoparticles or microparticles. They're slightly different. Hydrogels have been extensively used also in spinal cord injury, and fibers and conduits. So I have examples of materials that you can use in order to produce these different biomaterials, but I want you to focus on the benefits and the advantageous properties and the limitations of each one of these classes. So if we think of particles, they're very useful because the chemistry is very defined. It's very easy to manipulate these molecules. So we can tune the way the drug is released, and we can have it acting in a sustained and prolonged manner locally. However, and we know that after spinal cord injury, often there's the formation of a cavity and a cyst, and these particles are not able to provide support for cells to regenerate in those areas. That's why hydrogels are very interesting to use in spinal cord injury, because they are injectable, and you can, with one injection, considered maybe minimally invasive, you can introduce this material and have it adjust to the irregular shape of this lesion. One of the limitations of the use of hydrogels is that it's more difficult to control the properties of the gels. You need to do a series of modifications, and you don't have guidance cues that are maybe necessary for the extension of axons and reconnection and repair of the tissue. So that's where these other kind of materials come, the so-called fibers or conduits. Usually they are aligned structures like you see in here, and you can have cells growing and following this direction in these tissues. So the main advantage is providing these guidance cues for axon regeneration. The problem with these materials is that the mechanical properties are usually very different from the spinal cord, so they're a little bit stiff, and putting these materials into the cord can cause further injury, and also it's a very invasive method. You cannot inject, you actually have to open the cord and insert the material, so it's still not ideal. Whether we use particles, gels, or fibers, there's a series of properties that biomaterials should have and should be considered in research if we're talking about clinical application. So ideally, these materials should all degrade and eventually be replaced by the regenerated tissue. The products of degradation should not be toxic, so these materials should be biocompatible, do not elicit extreme immunogenic responses. It's an advantage if we have surface chemistries that allow for further functionalization, so we can add proteins, drugs to these materials to deliver. They should have a structure that allows transport of oxygen and nutrients, so we can still have the appropriate environment for the cells to grow. Cells should adhere, proliferate, and differentiate in these materials. Another important fact is that they should be able to be sterilized. So if we want to eventually implant this in a patient, we need to be able to sterilize these materials. As I mentioned, hydrogels have this moldability property that it's very attractive for spinal cord injury. I also mentioned the mechanical properties should match the mechanical properties of the spinal cord because we don't want it to be either collapsed or we don't want it if it's too stiff to cause further injury. And the porosity is also important to allow extension of the axons and regeneration of cells. So I'm going to show you one of the first works that was published in 2009 by the Belanconda group, where he used a combination of these materials to reduce inflammation after spinal cord injury. So he proposed the use of these circular particles. These are PLGA, polylactic glycolic acid, nanoparticles that were loaded with methylprednisolone. He used it as a standard drug that we know it's going to be anti-inflammatory. So he induced a hemisection injury in the spinal cord, and then first he injected the nanoparticles into the lesion, and then he covered the lesion with a hydrogel. In this case, he used an agarose gel just to prevent leakage from the nanoparticles, and they were able to observe release of methylprednisolone for 3 days. As you can see, on the first 24 hours, they had a high release of the drug that was significantly decreased and maintained for 2 more days, but at day 4, you couldn't see anything else. So it was still a kind of a limited system, but he tested it. They did see improvement in locomotor recovery. I'm not showing here, but the mechanism that they proposed was through the inflammation. They showed that when methylprednisolone was released locally in the spinal cord, it was neuroprotective, as you can see by the reduction in the lesion size. So this first image is the local delivery of methylprednisolones with a gel versus a systemic administration of methylprednisolone, which was the standard treatment, let's say, and then compared to a saline injection and a single methylprednisolone local injection versus the systemic. So the best result they got with the local sustained delivery of methylprednisolone using these nanoparticles. So since this paper, a lot of other labs have been exploring this local sustained delivery. And today I'm going to propose something that was developed by one of our collaborators, Professor Ki-Bom Lee from Rutgers University. So he's a chemical engineer, and he developed this material that has interesting properties for spinal cord injury that I'm going to mention. So our hypothesis is, and we're going to follow a similar paradigm, so when we cause an injury to the spinal cord, and I'm again talking about transection injuries, we know that we have increased pro-inflammatory cytokines, and that leads to neuronal damage. So we proposed to evaluate the implantation of porous three-dimensional scaffold in this lesion with methylprednisolone. And through this local anti-inflammatory treatment, we were expecting enhanced functional recovery. So I'll show you what's interesting about this material. So this is a scaffold that is made of these nanosheets. So these nanosheets are made of manganese dioxide. They are very controlled. So as you can see, the structure is very organized at the nanoscale. And even this high-resolution electron microscope shows you how they're even orderly organized at the atomic scale. So it's very, very controlled. And this allows for the possibility to tune certain properties such as degradation, porosity of the material. It also allows for efficient drug loading. It has intrinsic affinity to ECM proteins. We can have a sustained release using this drug, and also an interesting property that we're still not using but could be interesting if it moves further to clinical trials. It's that it has magnetic imaging properties, so you could actually see the scaffold on an MRI image. So following the implant, where is it exactly implant, how it degrades. So this might be an advantage for this specific application. The way this material is produced, as I told you, it starts with the deposition of manganese dioxide to form these nanosheets, as you can see here on the left. And then to create the three-dimensional structure, our collaborators actually added positively charged chitosan molecules. Chitosan is a natural polymer derived from the exoskeletal of insects, and it's actually very widely used in tissue engineering. So this will cause these negatively charged nanosheets to form the three-dimensional structure. And they also incorporated our drug methylprednisolone to test if it's released, then it can reduce inflammation. This is how the scaffold looks. We have the three-dimensional structure of the sheets with methylprednisolone, not physically entrapped, but actually it's binding to the material. And then the positive and negative charges maintaining the structure intact. So, next thing was to look at the structure of the scaffold. And I told you that one of the advantages was the ability to actually modulate the properties. And now I can tell you that the only thing you need to do is to change the concentration of the manganese dioxide, and then you have a different structure. So it's a very easy thing to change, and that alters the porosity of the scaffold, as you can see. So we start with the lowest concentration we tested was this one, and you see a highly porous structure. And as you go up in the concentration of manganese dioxide, you see how we increase the size of the pores, and we create totally different structures just by changing the concentration. So we also wanted to see how this affected the degradation of our scaffold. And on this graph above, you can see just a very simplistic way of assessing degradation, just placing the scaffold in an acidic solution and assessing how long it takes for it to be completely degraded. So if we use lower concentrations of manganese dioxide, you see that the scaffold is degraded very fast. As we increase the concentration of manganese dioxide, we're creating a more stable structure that actually takes longer to degrade. This is just, as I said, in an acidic solution. So to try to mimic the interaction of cells and the environment with the scaffold, our collaborators also tested degradation by culturing the scaffold. The black material here is our manganese dioxide scaffold, and they just place it in the bottom of a tube, having cells in here on the bottom and the top, so it's placed in between two layers of cells. In this case, they used neural stem cells, and they just looked at the aspect of the scaffold, and it's very clear to see that with time, the scaffold starts disappearing. After 21 days, we can still see a layer of scaffold, but there's significant degradation compared to our initial time point. Next, we wanted to check if the drug was being released and how was it being released from the scaffold. Again, we used different concentrations. And actually, let me correct, when I say we used, they used. This was done in our collaborators' laboratory, it wasn't me. But they tested, again, different concentrations of manganese dioxide with the same amount of methylprednisolone loaded in the scaffolds. When we have, again, that very porous structure at the lower concentration that we tested, we have a very fast burst release of the drug. So let's say about 60% of the drug is released in the first 24 hours. As we increase the concentration of our material, we have a slower and more sustained release that also lasts longer. So we tend to be more interested in this range here for our experiments. So after this characterization of the mechanical properties and drug release, the next step was to test this material in a cell culture system. They chose to use primary macrophage cultures and test the induction of an inflammatory stimuli and how methylprednisolone and our scaffold can rescue that. So they used a control group only with culture media to induce upregulation of pro-inflammatory gene expression. They added LPS to these cell cultures, and then they treated with either a solution of methylprednisolone or the methylprednisolone in our scaffold. So they did qPCR analysis of some pro-inflammatory cytokines that you can see here, IL-8, IL-6, CXCL1, and CCR7. As expected, adding LPS to the cells led to an upregulation of these pro-inflammatory cytokines. And both methylprednisolone as a solution and methylprednisolone in the nanoscaffold were able to reduce significantly the gene expression of these pro-inflammatory cytokines in all the conditions that we tested. So the drug that is released, we now know that is biologically active and is interfering with inflammation. So then they send the material to us. Yes?
Did you use the scaffold alone to see if it has an effect on the inflammatory properties of nanoparticles? Or did they add it?
I don't think they checked that. They didn't add that group. No, I don't think so.
The LPS and the control and the other two groups have methylprednisolone.
Yes. So the control group would be only cells, I believe, according to the information I got, and the LPS, and then methylprednisolone with no scaffold in the culture, and then the only one with scaffold is the group with methylprednisolone and nanoscaffold. So yeah, we don't have that group. That would be interesting to assess as well. Mm-hmm.
How long after exposure to LPS?
I believe this was a couple hours after LPS. Yeah. No, we did in vivo. I don't think they looked at IL-1 beta in the culture system. So after this next day, we got the material from them, and we started looking at also a series of pro-inflammatory cytokines that we know are upregulated in the first day after injury. The animal paradigm we used was a dorsal hemisection lesion in a mouse. And right after the hemisection, we decided to implant the scaffold in the lesion side first, and then we waited 24 hours before collecting the tissue and quantifying, again, pro-inflammatory gene expression using qPCR. And we also tested those different concentrations that they say. So in here, you can see different concentrations of the manganese dioxide and how they affect the drug release and the action in inflammation. So you see that also the anti-inflammatory effect is concentration dependent. So from here, and we saw a reduction at this concentration in TNF and IL-1 beta, and then we extended these, and actually we decided to test the drug scaffold against the control scaffold with no drug in the animal, and we have the data here in the bottom. So for IL-6, CCL2, and other pro-inflammatory cytokines, we also saw a reduction, not a global reduction. Some cytokines we actually didn't have an effect, but we saw that there was an anti-inflammatory effect acutely after implantation of these injuries. So this was exciting data, and we decided to do a more extended study. So we did the same injury paradigm. Yeah, we used the highest concentration, yeah.
I was thinking that 2.4 would have been better on the previous slide that you showed in terms of...
Actually, sometimes I get confused with that because we did so many experiments. We tested, I can double check. I believe it was the highest one.
Both of them had a nice sustain.
Yes, 1.8 and 2.4 were more similar, yeah. So I'm not showing all the data. We did a series of, we tested different concentrations of methylprednisolone with different concentrations of manganese dioxide. I believe for this one we used the highest one, and then we chose that to continue with our studies. So we used the same injury paradigm, mouse model, dorsal hemisection, and then now we follow the behavior of these animals. As a proof of concept, initially we wanted to test the scaffold with the drug compared to the scaffold by itself, just to see the effect of the release of methylprednisolone. And we let the animals survive for a month. We did weekly BMS. BMS is a scale of locomotor function and hind limb movement that it's commonly used after spinal cord injury. And we did see that the animals that had methylprednisolone in the nanoscaffold were performing better and recovering faster than the animals that had the scaffold and no drug.
So how does it compare the MNO2 with the spinal cord injury alone?
We didn't do that. Initially, we had, when we were testing the different concentrations, we were comparing with that group of spinal cord injury. And it wasn't similar, it was a little bit worse than the spinal cord injury. We still decided to continue the study anyway as a proof of concept and just to see, okay, is the drug being released in a way that can actually reduce inflammation? So I'm gonna mention later on my talk, this material as it is, we don't think it's the material that should continue. There's still some alterations we have to do, especially in the mechanical properties, because it's still a little bit rigid to implant in the cord. But again, yeah, we just used it as a method and an experiment to test the drug release from the material. So from now on, yeah, we didn't have the spinal cord injury group. However, we did this experiment twice, so we did 2 independent experiments, and we were able to replicate this data. So in both experiments, then at different time points, we have very similar behavior data. And then we were interested in looking at the histology. So what is methylprednisolone doing? So I have 2 sagittal sections of the spinal cords. On the top, you can see the group that had implantation of the scaffold only, and then below the material with the scaffold releasing methylprednisolone. In red, I have GFAP staining, so you are seeing astrocytes in red, and then we used PDGF receptor beta in green to label fibroblasts. So the most striking thing that we could observe was an attenuation of the fibrotic scar. So when the material was releasing methylprednisolone, we were seeing completely different fibroblasts in the lesion site. We tried to measure this by looking at the intensity of the fibroblasts here in the border, because in this case, it also looked that this border was more intense, and we saw a reduction in the signal of these fibroblasts in the group with methylprednisolone. And I want to show you this as well. So we always expect some variability in when we do our animal studies, especially in spinal cord injury. But I thought it was very striking and clear to see that most animals in our control group that had scaffold had this appearance of a lesion with a very defined fibrotic border. And in the methylprednisolone animals, it was totally gone. So we know from Jay's previous work, that fibroblasts usually come after macrophages when they infiltrate. So the next step was to look at macrophage infiltration. So I stained the tissue with CD11B, and I focused my attention on the macrophages that are infiltrating here the injury site. And methylprednisolone, we know it's the mechanism of action, and we actually confirmed that methylprednisolone reduced the infiltration of macrophages to the injury site. So again, when the drug is locally being released from the scaffold, it's very active and it's doing its intended benefits. We are now also interested in looking at the number of axons around and caudally to the lesion. So we stained for 5-HT, you can see in red, to see serotonergic axons. And we were focusing on how many axons we can see in here in this area. We were able to see more axons extending in caudally to the lesion in the methylprednisolone group and going longer distances, as I intend to represent in this graph here. This is 1 month. All this histological data is at 1 month post-injury. So just to wrap up this first part of the talk, I hope I convinced you that this material has very advantageous properties to be used in spinal cord injury, so we can very easily tune degradation and release rates from this material. We saw, according to our data, that local methylprednisolone release decreases acute inflammation, decreases macrophage infiltration, and attenuates fibrotic scarring in a spinal cord injury area. And we also saw that it was improving locomotor function compared to the scaffold only. So this material provides a sustained spatiotemporal delivery of methylprednisolone that can be very attractive for future, more effective therapies. I also want to show you other works involving this material. So this material is actually having a lot of attention from other groups. This is a recent work published, our collaborators published this work, and in here they showed that this very same nanoscaffold supports differentiation of iPS cells into neurons. So I would ask you to focus here. This is a control scaffold and the manganese dioxide scaffold with 2 Schwann positive cells. And then if you add laminin to the system, you have even more cells differentiating here. So this is an additional property that this material has to actually support cell adhesion and differentiation. And last week, I ran into this paper that I also wanted to mention. So another group, instead of producing a scaffold, they produced nanoparticles out of this manganese dioxide material. And I thought it was very interesting that they found that it has an antioxidant effect. So the particles themselves have this property of reducing oxidative stress, and I'll guide you very briefly through the data. So they have a hydrogel. They use an hyaluronic acid gel with nanoparticles of manganese dioxide compared to a blank hyaluronic acid. In vitro, they induced oxidative stress using hydrogen peroxide, and they measured reactive oxygen species in the culture system. And the cells they used were MSCs, mesenchymal stem cells. So as you can see in the quantification here, the blank hydrogel compared to the signal of reactive oxygen species we have when we have the manganese dioxide nanoparticles, it's significantly reduced. And this translates into a higher survival of the cells in this system. So this is also a very interesting intrinsic property of this material. And as I was saying, we showed very interesting properties of the material, but I don't think it's ready to be tested in a clinically relevant model. And we've been actually talking to our collaborators, and they have now in hands an hydrogel made of these manganese dioxide, and that would be an interesting material to inject into a contusion cavity and see if we can still have all these beneficial properties using this material that can be injected. So that would be the next step in this project. So today I'm going to mention another strategy that we recently came up with to target, I say cell-specific particles. Our goal is to target macrophages, the cells that are mainly responsible for the inflammatory processes after spinal cord injury. So now I'm going to show a different approach using particles only, no gel, no scaffold. The advantages of nanoparticles are, again, that they have very defined chemistries and you can do a series of modifications. I have some examples in that illustration there. But you can also add smart materials that react to differences in pH or temperature. So they're very attractive as a drug delivery system. And the main advantages are that they provide a sustained release of the drug. As the drug is encapsulated in these nanoparticles, it's actually protected from degradation. Sometimes enzymes degrade drugs, or even pH from the media. So they're more protected and can be effective for longer periods of time. We can also achieve intracellular delivery of the drugs. And even, depending on the size of the nanoparticles, nuclear transfection of genetic material. There's also a lot of work using nanoparticles for that. And with all of this, we're increasing the efficacy of the treatments and minimizing those side effects that I mentioned to you. So these are some classes of nanoparticles. I'm not going to go through exhaustively. But as you can see, according to the intrinsic properties of nanoparticles, they are preferentially used either for drug delivery. As you can see, polymer nanoparticles, dendrimers, and liposomes tend to be used for drug delivery. Some other particles are more attractive to be used as imaging agents, and quantum dots are very good imaging agents, magnetic nanoparticles, silicon nanoparticles. The material of choice for our work is going to be liposomes, so I'm going to talk to you a little bit about liposomes. And what is interesting about liposomes? So first of all, they're in the market. There's a lot of liposomes that are already used for different applications, mainly for cancer. So you have, for instance, liposomes carrying doxorubicin and other anti-cancer agents. They are also being used as vaccines, for phototherapy, as analgesics, antimycotics. So there is a market already with FDA-approved and clinically used liposomes. Not only this, but there's a line of other new formulations of liposomes with more drugs, either for phase 1, phase 2, phase 3 clinical trials, all for drug delivery. So it's actually an expanding market and very interesting. And why is that? So the main advantages of liposomes is they are biocompatible. As you can see, and you probably know, liposomes are made of this bilayer lipid that really resembles the cell membrane. So it's biocompatible. It's easily degraded. So the lipases in our bodies easily degrade these liposomes, even intracellularly. They're also amenable to surface modification, so we can add ligands or other molecules of interest to our systems. And I just have a mention there. So there's a lot of engineering using liposomes, creating these hybrid structures of liposomes with micelles inside. So there's a lot of work in engineering these liposomes to better particle systems. The advantages that are usually associated with the use of liposomes are a limited shelf life. So for instance, I'm producing liposomes in the lab, and I know that I should use the liposomes in a week when they're in solution. If they're optimized and produced with all the quality control, you can have the liposomes for about a month, but it's still a limitation, the shelf life for the use of these molecules. They are preferentially taken up by macrophages and phagocytic cells, and they have slow release profiles. But in the lab, what we're thinking is to actually use these disadvantages in our favor. So why don't we use macrophages liposomes to target macrophages? And this is not new. It was described in the literature. And you might be even familiar with this first publication that originated now a commercially available kit of clodronate liposomes that are injected in the animals, specifically target macrophages. And in this case, the goal is to actually kill the macrophages, induce apoptosis, and delete the system from macrophages. But we can also use that using other drugs and modulating the response of these cells specifically. And there's other groups. This is a recent paper where they're even trying to engineer liposomes to target different subtypes of macrophages. So this seems like an interesting system. Again, we can have a liposome with multiple drugs that we know are going to modulate our macrophages, even genetic material, and they are going to do all the work and phagocytose these materials. So Jay has used these commercially available liposomes in the past. And this is some of the data. So after a spinal cord injury in a mouse model, it was Inzhao, he injected these commercially available liposomes. In the case, they were using dye, which is a red dye that allows identification of the liposomes in the tissue. They injected systemically, and then they looked at 7 days and 14 days after a spinal cord injury to see where were these liposomes located and which cells were co-localizing with them. So in here you can see CD11B staining, and I hope you can appreciate that the red liposomes are inside these white membrane cells, so macrophages in the lesion side. And when you look at fibroblast cells, there's no co-localization. So there's a specificity to this system again. Both at 7 days and 14 days, they were able to observe that. In the work that Jay was doing, they were actually interested in depleting macrophages. So again, they used the clodronate liposomes, and you can see in here, this is a PBS liposome system. This is the normal macrophage infiltration. When we use this system with clodronate, you can actually have a significant reduction of macrophages in the system. So it works. It targets macrophages, and the drug that is inside this liposome acts according to your desired action in the macrophages. So because I want to incorporate not claudronate, but other drugs, I'm making these liposomes in the lab. It is a fairly simple process, actually not that complicated. So you just buy the phospholipids you're interested in. We are using phosphatidylcholine and cholesterol, trying to mimic that commercial liposome formulation. And then you just go evaporate the solvent. They will self-assemble in different sizes of liposomes. And then we use an extrusion process to actually define the size of our liposomes. I'm trying different sizes, and then you can further purify this formulation in order to have a monodisperse solution of liposomes containing whichever drug you're interested inside. So these are my first liposomes that I did in the lab. I'm glad we have a transmission electron microscope, by the way, because there would be no other way. So at the time, I was just testing nano-sized liposomes. So these are circular shaped as expected with very monodispersed similar sizes. I am now producing larger liposomes because the bigger they are, the more specific they are to macrophages. So I'm working on that. In these liposomes, I incorporated the same dye, that same red dye inside, and I added it to bone marrow-derived macrophage cultures to see if they were being internalized by macrophages. And you can see that at 2 hours, they were inside the macrophages and dispersed within the cells. So the idea now is to use this system, so a specific liposome that will target macrophages, and we're also interested in testing novel targets in neuroinflammation, and this also comes from another project that we have with Jay and Nagy, targeting BET proteins, and I'm going to mention a little bit of the work that we have and why we're interested in targeting this. So this project started with a PhD student in the lab, Michelle. So her thesis, the hypothesis was that these bromodomain and extra-terminal domain, so short name is BETs, these proteins, these epigenetic readers, are responsible for the upregulation of the inflammatory cascade that follows spinal cord injury. If that is the case, then when you use an inhibitor molecule for these proteins, and we're lucky that there's a lot of interest in these BET proteins, so there's a lot of small molecules that selectively target these sites. So if we inhibit the action of these proteins, we'll be able to reduce inflammation and have neuroprotection in the tissue. So Michelle tested this first with a tool compound, one of the first ones that was available in a contusive injury in mice. And she saw a reduction in pro-inflammatory mediators at 3 days after injury. And she confirmed that with qPCR. This is an PCR array. She also looked at infiltration and saw that inhibition of these BET proteins was actually very effective in reducing infiltration of immune cells, mainly leukocytes, macrophages, and neutrophils. And again, this is at 3 days post-injury. However, when she was looking at the behavior and at the lesion size, she saw no difference at 1 month. And there might be several reasons for this to happen. So first of all, BET proteins are not exclusively in immune cells, so we might be having undesired actions of inhibition of BET in other cells, such as astrocytes, and affecting other mechanisms. And we're also, again, using that high-dose systemic administration that it's not specific to immune cells. So those 2 reasons might be leading to this result. So there's several things we're doing in the lab to further test this. So I am now using a more clinically relevant model. I'm using a contusion injury in rats. And also we changed the drug. So this JQ1 molecule has a very short half-life. And as I told you, there's a lot of interest in these molecules. There's actually clinical trials with this molecule here, IBET-762. It has passed safety, I believe, and it has increased drug-like properties, so we're testing these other inhibitors. And first we looked at acute inflammation in a rat contusion model, and again, we did a dose study. I'm not showing you all the data, but we reached a level where we found a dose that was actually effective in reducing acute inflammation. So from here, we decided to move again to a long-term study, but that's where we started dealing with a lot of toxicity issues. So it was very difficult to find the right dose. The rats were lethargic. We were experiencing mortality. So we sat down and we started thinking, okay, what are we going to do? And we came up with this idea of using the liposomes and tried to test these bad epigenetic inhibitors to reduce inflammation by using a more targeted approach, and that's what we're doing now. I'm going to test the distribution first of these liposomes with the drug and then do an efficacy study. Just want to add that we also have other ideas of using new drugs and new drug combinations. So Nagy works a lot in drug discovery, and he has these cool platforms to find synergistic combinations of drugs, and we're also using those tools to predict combination and test in this system. So that's it for now. I think I'm good in time. So just 3 take-home messages that I would like you to live with. So I hope I was able to show you that local anti-inflammatory therapy using biomaterials increases the efficacy of these treatments, minimizes side effects, so it might be one of the directions to go towards a more effective therapy for spinal cord injury. The manganese dioxide nanomaterial has a lot of interesting properties, and it can actually be turned into different hydrogels or particles, and we're going to continue using it for spinal cord injury repair. And then we have available tools to target macrophages. They're commercially available, and we're going to use it to modulate the innate immune response. I hope to have soon cool data to show you on this. And meanwhile, I want to thank everyone in the lab, in Jay's lab, Nagy's lab, Michelle, and some of the students we're having, also animal facility and funding agencies. And thank you very much for your attention. And if you have any questions, I can answer them now. Yes.
My question is, how do you intend to deliver these liposomes? Locally or systemically?
Systemically. So when the protocol for the clotronate liposomes is systemic administration. So IP.
To deplete these macrophages?
No.
To target these macrophages?
I want to target the macrophages before they reach the injury, exactly. So modulate their behavior, make them do what we think it's beneficial before they reach the injury, yeah.
Would they also enter the CNS eventually, these liposomes? So for example, would they enter the CNS and perhaps be phagocytosed by the microglia?
I believe the only way I'm not sure about that. I know they are specific for macrophages. I believe the only way they enter is through macrophages. The liposomes themselves, because they are big enough, usually they use 500 actually the commercially available ones are 1500 nanometers, so it's actually microparticles. Microparticles would not have the ability to enter the CNS without being transported by macrophages. So I don't think that would be a problem, but it should definitely be tested.
We tested that with the chimeras. These liposomes don't get the way we use, so we don't see
If you inject locally, it will. Yeah, locally it will be taken up by microglia, but systemically it will preferentially target macrophages. Yeah, that case, yes, yeah. But again, our goal is to have them. Yeah, the possible. Oh, yeah. Oh, we can talk. Yes, Ines.
Two questions. One related to that, as a follow-up. Would you expect any negative effects of
early?
Right. So that's an ongoing discussion, right? There's people, inflammation is needed, right? You need to, a lot of functions of the immune cells are necessary for injury repair. The thing is that can we direct, we know that there's a lot of uncontrolled immune response in spinal cord injury, so we're trying to control that. And then there's never a resolution of the cells just remain there, even in chronic stages where they're not necessary. So there's a lot of things that can be improved, and we hope to do with this system. But yes, there needs to be a balance. I know I'm not answering your question, but there's a discussion, yeah, how long should you leave like the inflammation occurring, and then, yeah, it's something we need to try. The time points of action, it's something that needs to be tested too, yeah.
Sorry, the other one was about the Edison. We know it has also immunomodulatory and neuroprotective effects by itself.
Okay.
So is there any other, you said they didn't use it as a proof for that experiment that you were showing, but have they done any experiments in vitro or in other animal experiments with the biomaterial itself? Is that the methylprednisolone?
We did initially in our pilot study. Compared to the injury, we saw increased inflammation acutely and in the behavior again. But I believe it's because this material, it's because of the mechanical properties of the material. The amounts of chitosan are very, you're focusing on my chitosan. I don't know if you're referring to the inflammatory effects of chitosan. The amounts of chitosan, I think, are not enough to cause a response. We didn't study that well the response to the material. We were focusing on the response to the drug release. So I don't have a lot of answers to that question, but it's something to consider in the future, of course. Now that we have interesting data and we know that we have desirable properties, we need to do an extended study with all the control groups and analyzing that. But again, I am more interested in using now the hydrogel formulation and not this scaffold that I'm showing you. This was an initial study to test this material. But yes, yeah, I'll do that. Yes?
Very interesting talk.
Thank you.
I was just wondering when you were talking about the, is it methylprednisolone? So when you were talking about how it attenuates the fibrotic scarring and you marked the axons with 5-HT, I was just wondering if like you happen to look at any other markers like CTB or see if
Yeah, we didn't trace the axons. We didn't do any tracing. We didn't use any other neuronal markers. This is our very preliminary data. I still don't have an answer for that, but of course, we can do that later on. Yeah.
And then I was just wondering if you know if there's any literature on like the combination of two of these different materials, like with the particles and the hydrogels, if there's anything about that.
There's a lot of work combining nanoparticles and hydrogels, different nanoparticles, different drugs, different hydrogels. So for these specific materials that I'm showing today, I don't think so, because it's a very recent material. All the data that I'm showing you and even the publications, though I showed one from last week, so people are starting to explore this particular material. But you have a lot of work in, I would say, in the last decade, exploring nanoparticle combinations with hydrogels for spinal cord injury and other diseases, which is always interesting to go to other areas, see what they've done, and then try to apply. Yeah. But there's a lot of work, yeah. Mm-hmm.
With the scaffold, I always wonder how clinically relevant scaffolds are. There's a lot of funding for them, and a lot of people are doing them. But for the Schwann cell transplants that we've done, when I've been in the operating room, just to inject fluid, it's very difficult in chronic injuries. There's not a big space to stick something in there, and so I just wonder, how clinically relevant do you think scaffold implantations are?
So it depends what you mean with scaffold, because scaffold we can be talking about hydrogels or we can be talking about those conduits, right? And it's a totally different approach. So I have worked before with Schwann cells and scaffolds when I was in Mary Van Gilag. So what we were proposing, and I think it's very clinically relevant, was to use the same injection of Schwann cells. In the syringe, you have the gel and the cells. So for the Schwann cell injection, you do the intraspinal delivery, right? So if you add to the bolus of the cells the material, and it can be injected and fill the lesion and do what's intended, I think it's very, very relevant. If
you used the liquid suspension that sort of had all of the other connective tissue and parts of the structure, of the nerve structure, is that what you're talking about?
Yeah, the acellular nerve. Yeah, exactly. I was injecting a gel that was made of extracellular matrix proteins along with the Schwann cells, and we had nice data with that. Again, if you talk of scaffolds as those conduits, it's a totally different conversation. However, there was approval for clinical trials with those scaffolds, and they ran into some issues, but I heard that they're actually trying to do those trials again, even with rigid scaffolds. In my opinion, I'm not a surgeon. I think this is a conversation to have with surgeons. I think it's more invasive, more complicated, but the hydrogel alternative is very attractive. Yeah, and you don't need an extra procedure to do it if you're doing cell transplantation. So I think it's the way to go. Okay, thank you. Thank you for coming.